Hello everyone, this is Dr. Mandeep and welcome back to Clinical Case Series. So, in the last video, we were discussing about a case and that case is a 48 female with nausea, vomiting, breast pain, breasts were tender, enlarged, she had headache. We concluded that she had euvolemic hyponatremia and the cause was SIADH due to pituitary adenoma. So, the question towards the end of the video was how to confirm pituitary adenoma. We will answer that question a bit later. Before answering the question, let's dive into what is SIADH. So, SIADH is syndrome of inappropriate ADH secretion. Syndrome of inappropriate ADH secretion. So in this syndrome, you have excess of ADH. Excess of ADH. Now, what is ADH? ADH is anti-diuretic hormone. So, what does the name suggest? It means it prevents or decreases diuresis. Now, where is it made in the body? It is made in the hypothalamus. It is made in the hypothalamus. Once made there, it is transported to the posterior pituitary. So, the posterior pituitary stores it and releases it whenever needed. Let's dive into what are the things that ADH controls and leading to its secretion in the body. So, posterior pituitary, as we know, it stores the ADH and it regulates two things. These two are osmoregulation and volume regulation. So, whenever the serum osmolality it increases, the antidiuretic hormone ADH increases water absorption. Whenever the volume falls or the blood pressure falls, the body senses that it needs more volume. So what it does? It secretes ADH to increase water absorption. In both the cases, we saw that water is something that is correcting the abnormality. That abnormality was high tonicity high tonicity in osmoregulation and low blood volume in volume regulation. I hope this is clear to everyone. So, ADH is synthesized in the hypothalamus and is stored in the posterior pituitary to have control over two things. One is osmolality and second is volume. So, whenever there is whenever there is increase in osmolality, it means the body's water is less. So ADH would increase water absorption so as to correct the osmolality, right? Secondly, whenever the body volume is low, the ADH would be secreted to increase water absorption, thereby addressing low blood volume. Let's move on to the effects of ADH. So, ADH produces its effect via two receptors. These two receptors are V1, V1 and V2. So, if we go into the details of these, V1 receptor is present on blood vessels, while V2 receptors, they are present on collecting tubules. The action of ADH on blood vessels via V1 receptor causes vasoconstriction. Now, because it causes vasoconstriction, it is also named as vasopressin. If we divide the name, vaso is blood vessel and pressin is constriction. While V2 receptors in the collecting tubules of kidney increase water absorption via increasing aquaporin 2. So let's revise these two receptors of ADH. So ADH has V1 receptor and V2 receptor. V1 receptors are present on blood vessels, due to which it causes vasoconstriction. That is why it is called vasopressin. While V2 receptors present in collecting tubules of the kidneys, they cause water absorption via aquaporin 2. I believe it is clear to everyone. Let's move on to the regulation of osmolality and blood volume by ADH so as to understand how SIADH can be diagnosed in a patient. So, ADH, as we discussed, maintains osmolality or tonicity of plasma and blood volume. So, serum osmolality is maintained between 280 to 290 milliosmol per kg. When plasma osmolality is below 280, when plasma osmolality is below 280, there is little ADH secretion, because promoting water absorption in the presence of low osmolality would further worsen serum osmolality, right? It will become much lower if water is absorbed. So ADH is low, rather very little. So you would expect, because ADH promotes water absorption, urine would be minimally concentrated. And in such cases, urine osmolality is lower than 100 milliosmol per kg. But what happens if someone has SIADH? Despite low serum osmolality, there would be ADH secretion, and that would concentrate the urine. So, in our patient, as you can see the investigation on the upper part of the screen, the serum osmolality is 266. The serum osmolality is 266. And the urine osmolality is 460. Too much, right? It's 460. So, if serum osmolality in a normal individual is less than 280, the urine osmolality should be less than 100, because there is little ADH secretion. But what is happening in our patient? The ADH is being secreted inappropriately, so it causes the urine osmolality to be much higher. And if you compare these two, it is almost 2 times, right? So one of the key clues in patients with SIADH, that serum osmolality is almost half, or the urine osmolality is nearly 2 times, right? So I hope this is clear to everyone. So we have discussed that syndrome of inappropriate ADH secretions causes high levels of ADH, which concentrates the urine to the extent that it almost 2 times the serum osmolality, right? So let's approach what are the causes of SIADH. So in case of SIADH, anything in the CNS would cause ADH to be released. Those conditions which cause ADH release are any kind of stroke, hemorrhage, trauma, or tumor. In our patient, she has a pituitary adenoma, which is a tumor, which is causing SIADH, right? There are more conditions in the CNS. It could be meningitis, encephalitis, any lesion in the brain is causing SIADH. There are more causes of SIADH. There are certain drugs that cause SIADH. These drugs are carbamazepine, And the second one is a diuretic, which is chlorpropamide. And then the third category where SIADH happens is the pulmonary disorders. The pulmonary disorders. It could be any kind of pneumonia, bacterial, viral, right? The fourth category is malignancy. And which malignancy? Small cell lung carcinoma. The small cell lung carcinoma. And the last category is patients who have HIV. Patients who have HIV. There is one more condition. Where there is SIADH, and that belongs to the category of drugs. And that drug is SSRIs. SSRIs. Now that we have discussed the manifestations of SIADH and the relationship to serum and urine osmolality, let's move on to our patient. So, in our patient, we saw that she was having galactorrhea due to prolactin adenoma and the question towards the end of the last video was, how can we confirm the prolactin adenoma? So the investigation of choice for prolactin adenoma is MRI brain. And it is better than CT because it gives a detailed imaging. While CT may not be able to do so. Now, I have a question for all of you. And that question is, what are the signs and symptoms of increased prolactin in men and women? So that is where I will end my discussion. See, so if you have any doubts, have any questions, post them in the comment section of the video and we will come back and answer them with details, and we'll discuss what are the signs and symptoms of increased prolactin in men and women. I hope everyone enjoyed all of this discussion and we will be back again. Goodbye.